Good afternoon. My name is Jessica Perlow, and I am the ABIM Foundation's Executive Vice President. Thank you for joining us for our March Trust Conversations webinar, which is a core element of the Foundation's Building Trust initiative. Before we begin, I'd like to review a few logistics. This meeting will be recorded and shared. While our presenters are speaking, we will ask that lines be muted to reduce unnecessary background noise. There will be a chance at the end of our hour for the speakers to answer any questions you might have, and we encourage you to enter questions into the chat throughout the conversation. Today, we are joined by Dr. Nancy Oriel. She's Associate Dean for Community Engagement in Medical Education at Harvard Medical School and founder of the Family Van. And two Harvard Medical School students, Will Lee and Tyler Lecomer, who have worked with Nancy on the Family Van. Margaret Flinter, Senior Vice President and Clinical Director of the Moses Wiseman Health System and its Community Health Center. She's also a member of the Foundation's Board of Trustees, will moderate today's conversation. Thank you again for joining us for what I know will be a great conversation, and I'll turn it over to Margaret. Thank you, Margaret.
Great. Well, thank you, Jessica. Thank you to our people who will be joining us today in this discussion. And thank you all for joining us as guests. Really a delight to have a chance to moderate the conversation between Dr. Nancy Oriel, who is well known to many for her distinguished career in clinical practice, in education, and in service in medicine over the course of many years, and our two medical students who are joining us today, who are already making an impact as medical students and as future physicians through the choices that they're making. They had the chance, I really think a unique opportunity, to work with Nancy on the Family Van and are here to share some of their insights as well. So before we begin the conversation today, I think we're going to have a 90-second video. This is going to introduce you to the Family Van if you don't know anything about it or a little bit about it. It was founded by Nancy in 1992. And the Family Van is really just one example of an entire movement, I would say, of healthcare vans around the country, but it's a true exemplar. Through the video, you're going to learn more about the day-to-day operations of the van, but also, so importantly, the community that it serves, in this case, the Boston community, and the impact that it's had over the years. I have a feeling that some of you who chose to join today already are pretty familiar with mobile health vans, but if not, your curiosity has obviously been piqued, and I think you'll find it really fascinating, and we'll have opportunity for you to ask lots of questions. So we're going to have an interesting conversation, and with that, let's turn it over and have our 90-second video.
The Family Van is a godsend. Since the Family Van been around Boston, I am with them, and I will never give them up.
The Family Van is a mobile clinic that serves a number of different neighborhoods around Boston. We're reaching people who otherwise might not come into the traditional healthcare system. The healthcare comes to them.
We believe that healthcare starts on the street where you live, work, learn, and pray. And that's why we're there.
For the Family Van to be on a street corner on any given day, it's an opportunity for us to just sit there and listen and be the ears and the eyes and the hands that can make a difference in somebody's life for that day.
There's a warmth, there's a human understanding that tells you that you are important.
I feel at home when I go to the Family Van.
You never know what somebody is going through. So our job is to make sure that they leave better than when they came in.
I would not be cancer-free today had it not been for the advice that was given to me at the Family Van over 7 years ago.
I've been going to the Family Van for 5 years, and I recommend the van to anyone. And I'm not just saying it, but it's true.
There are resources to be shared, there's knowledge to be shared, and there's just an openness that is needed. The Family Van is a community of trust.
Really beautiful, powerful, short. And I think this is my opportunity to turn to you, Nancy, and say, again, congratulations on the incredible work that you've done. And I think you've given everybody just a glimpse into what a family van is, what a family van does, and what it might do in different settings and in different communities. But this would be a wonderful time for all of us to hear a little bit about your background, but also why we're here today to talk about building trust through community engagement and really using, in this case, the family van as our exemplar to talk about building trust through community engagement. So let me turn it over to you, Nancy.
Well, Margaret, thank you so much. And thank you to the foundation for inviting us. What can I say? 32 years. This is my home. This is my love. And I'm just so delighted to share it with everyone. So, you asked kind of where it came from and how it relates. Well, I am an obstetric anesthesiologist. And most people wondered why was somebody whose life is based in the OR end up creating something that works out on the street. And it actually, to me, makes perfect sense. One of the foundations of anesthesia is that, and I was lucky, I grew up in the days where we actually had a chance to see our patients before surgery. We would do a pre-op visit. And in that visit, your job would be to build trust with that patient in a very short amount of time, get to know who they are. I mean, imagine you're taking care of somebody, you're about to give them 20 different drugs. And meanwhile, what you don't know is somebody else is infusing norepinephrine in them, and you know nothing about it. Well, that's what fear does to you. So if your patient is afraid when you're about to give them anesthesia, they're getting infusions of stress hormones that are affecting what you're about to do. So the pre-op visit was a way to to deal with that, to sort of build trust and make the person feel better about what was about to happen. Well, that made perfect sense to me, and that's how I lived my life. And I was an obstetric anesthesiologist, so that's how I treated all my patients. Well, on one fateful day, and actually there were many fateful days, but one day, is sort of the origin story of the family van. Patient came in who was unconscious, had to put her, her baby was in distress. She had to do a stat cesarean section. The risk was both she and the baby might die, but they survived. It worked beautifully. But I went to see her afterwards because I wondered, what had happened? Why did this happen to her? And as I was talking to her, she said, well, she actually had insurance and she had prenatal care. But when she was at home having a headache, one, she didn't think that a headache mattered. And two, she thought it was too trivial to bother her doctor with. She didn't want her doctor to, judge her as stupid. And three, she was working two jobs. She didn't have time to go and check on it. So at the time, this was in 1992, and infant mortality was the headline, and everyone was saying that the problem was insurance and prenatal care. And I realized that it wasn't. It was more than that. And I also understood that the answer was outside the hospital. And so sitting in the coffee room with the midwife, we were talking about, well, what can we do? And the idea of, well, people needed a pre-op visit. They needed somebody out there helping them to understand their health, someone to give them the faith to believe in what they think is going on, and someone to build trust with the system so that they could come to it. So that was sort of the beginning, the nidus of the family van. 2 years later, we talked to everybody in the community. We built the van. It was built by the community. It wasn't started. I mean, it might have been nidus with us, but it was built by the community, and we've been doing it for 32 years. So that's where it came from.
32 years summed up very succinctly, a couple of powerful minutes. And I have to say, what a straight line from your work in obstetrical anesthesia, and up to the present time. You talked about 1992 when infant mortality was so much the talk. It's maternal mortality that's so much the talk today. The issues really haven't changed, and what a great exemplar of trust and community engagement you've just laid out. And I think we've put, in fact, a link to your paper on how trust plays into all this in the chat for people to take a look at. So thank you so much, Nancy, for starting us off with that. Will and Tyler, I'd like to turn to you. Your medical students fourth-year medical students, I understand now, and congratulations. I understand you've both matched. We won't spend the rest of the day talking about what that experience was like, but congratulations, you've matched, and we're very happy for you. But I'd love to hear about your experiences, and maybe Tyler, you could start, and then Will, your medical students, grueling schedule, you're in the hospital, you're in your clinical sessions. How did you come to choose, or did it choose you, the family van? What was your experience like, and what do you imagine the impact is on how you see healthcare and the practice of medicine in your own careers based on the experience? I know it's a long question. You can take it any way you like.
Yeah, for sure. I'm happy to get started. Thank you so much again for having us. I'm so thankful to be here with Nancy and Will, who I've become very close with over these past years. So for me, I got involved with Family Van as a component of a community engagement and immersion, really, into as a clinical rotation. And it's a clinical rotation that Nancy runs. And this clinical rotation I took immediately after kind of going through the very hard time of studying for the Step 1 board exam, which felt very kind of I was very one-track minded at that point, taking that exam. And so I took this clinical rotation because I was very interested in getting involved in the greater Boston community, and I wanted my first clinical rotation that I was coming back to be this, so then I could take what I learned from this rotation and bring it with me for the rest of my medical training. And I say that because in medical school, I think one of the main things that we end up learning is how to be efficient. And for everyone who's been in the hospital or been to a doctor's clinic knows that things move kind of, and a lot of times you get less time to speak with the doctor or speak with honestly any medical professional than you would like. And so the family van rotation gave me a chance to really just focus on conversation, focus on just slowing down and talking with people in a way that I feel like the rest of my medical training. And I like that I was able to focus on conversation as a clinical skill. Really, it's something that goes so ignored. And I match in anesthesiology, so I'm kind of following along Nancy's path. And she's been very much an exemplar to how within this field, which is allotted like much fewer minutes to have conversation with patients than a lot of other career paths are. She's been an exemplar for just how to make the absolute most of that, and to put focus into the person in front of you and into their life context in a way that I feel that the rest of medical training does not give as much light to. And so I was telling Nancy that the other day, I feel that this month that I spent getting to work full time on the family van, getting to work directly alongside with these community health workers that just know the community so well, know the people that are in front of them, and have the space and drive to just listen and help work with people. It was the most impactful month of medical school for me, because those things that I learned and practiced during that month, I've been able to carry with me, even on rotations where I'm given maybe 10 minutes with a patient at a time. And that is so important to me. And it's something that I think about even moving forward into, I'll be in New York City for residency. So even thinking about moving into a completely new city, one of the things that I was actually doing this last weekend is just walking through neighborhoods I'll be working alongside. And that is so important, just to understand the context of the patients that you'll be working with. And so that's something that I will continue doing, and all started with Nancy and with Will right alongside me. I think it's January 2023, but very, very impactful. And so thankful for that time.
Wow. Well, thank you, Tyler, for that. And just saying, I think you probably also maybe shed some new perspective on what anesthesiologists think about, what they care about, how they think about life for their patient before they arrived under their care, and what they will be going back to. Just hugely important. And again, I think gets to that trust issue. So thank you for shining a light on that. And William, how about you? Tell us about your experience.
Yeah. I echo so much of what Tyler's experience was. And again, starting by thank you for allowing us to tell our stories here. It would not be an exaggeration for me to say that the family van was one of like drawing factors for me to go to HMS. I did some community work in college, and I knew this is like a really important aspect that I want to continue to explore and be a part of my training and future career. I feel like, especially in Boston, it was kind of stands a stark contrast to the academic kind of ivory towers that exist in Longwood and Mass General and such, where my experiences in those hospitals, while it was a lot of like growth and learning like medicine and, you know, the process of being a physician and such, your face time with patients, like Tyler was saying, is really only on the outpatient floor is like 10 minutes a day, maybe, like on rounds. And one thing that the family van brought to me, similar to what Tyler was saying, was that breath of fresh air where like I can just sit and really be patient facing the entire time, focusing on their story and getting to know them better. Because it is true, I am a visitor into an institution that has been established in the community for decades now, where people come because they have familiar faces in the community health workers that are from their communities and speak their language and know their backgrounds. And yet, me being there, despite being a visitor, just being in that space and being, open to anything that the clients kind of wants to share or tell me, it's just really humbling to be able to like have that sense of trust, like kind of established immediately because I'm at the family van and working with the community health workers. I think that it's also a really amazing way for me to get to know the neighborhoods surrounding Boston, especially ones that kind of get overlooked and people don't really think about or really visit that much. And, it's not really a coincidence that these are places, despite being like pretty close in geography to like all these big academic hospitals, have a lot of like higher morbidity and mortality compared to other areas that Boston is kind of known for. And I feel like it was really important for me to be able to step outside of that, bubble at HMS and Longwood and really be able to see people where they are and feel like I am a part of their like life journey and like we're walking like this line together rather than like me examining a patient and treating their disease and such. So I feel like I'm going into pediatrics and, there's that layer of, your patient is child, but like a lot of it is interactions with the parents. And that's so much of the same lessons that Tyler mentioned kind of applies similarly, just about how to, in addition to having all like the medical knowledge and like treatment plans and such like that, be able to just make that connection in a short period of time with a patient who might be having one of the worst experiences in their lives, and so that was really, really powerful for me and a reason why I really hold that month dearly to my heart.
Well, as a community health center and primary care person myself, the obvious love for community and the recognition that you must know the community that your patients live in to really take care of them just really makes my heart sing. But I think, and maybe Nancy, this is for you, 1992, fast forward to 2024, the Affordable Care Act has intervened in those years to try and address the issues of healthcare access. But mostly what we read in the news seems to be two-sided. It's the breakthrough drugs, AI, marvels, and it's rising costs, access, as I said earlier, continuing issues with rising mortality, deaths of despair, all these unbelievable challenges that we have. When you think about the family van, is it needed more now than ever, even before we had innovations like the ACR? How have things changed in terms of what the family van needs to be prepared to respond to and to do in 2024 compared to when you started down this journey?
That's an amazing question. So human nature doesn't really change, and the human body hasn't really changed. How we treat it has changed a lot. What for the person on the street, it's their human nature. It's their sense of the healthcare system. It's their interaction with the healthcare system that's affecting them most. So we might have the greatest drugs inside our hospitals, but that's not going to do you any good if you won't even get into the hospital to begin with. So I had always hoped, in fact, I think that on the very first day that we opened the family van, gave a little talk, and I said, well, I had this vision that we were going to go out and build bridges into the healthcare system, and we would build trust, and we get everybody connected, and that we actually wouldn't need the van. We were going to just, spread love, and it was going to be a beautiful thing. Well, I discovered that's not actually true. It takes a very long time to build trust. And building trust one time, with one person doesn't do it for the whole community. Our community keeps evolving. Our problems keep evolving. Now, one thing the mobile clinics, all mobile clinics do that's unique is we're mobile. Okay. We can go where the problem is. And because we're small and usually scrappy, we can also change as needed. So when the issues on the street change, we change. In fact, it was sort of interesting. We saw the diabetes epidemic come before it made it to the Globe headlines because we were on the street and people were coming to us and we were checking their glucose, and all of a sudden we're just seeing more and more and more that are rising. It's like, oh, there's something happening out here. So when you're on the street, you actually have a finger on the pulse. So mobile clinics, we change all the time to address the needs as the needs change. And the needs keep changing. The other thing we do is we educate. People come to us and they listen to us. They ask us questions. Our model of care is called the knowledgeable neighbor. Now, I mean, how many doctors, when you go to a cocktail party, somebody comes up in you and says, I have this thing I'm kind of worried about. What should I do? Well, the people in our neighborhoods don't go to a cocktail party with a doctor, so they don't have a knowledgeable neighbor to ask. So they come to the family van. And they say, we know, so-and-so said this, but is that true? And what should I think about? So we help spread knowledge. And as the understanding of healthcare, as healthcare is changing, we help spread the new knowledge to our clients. During COVID, we were incredibly important in helping people understand what to do. In fact, we had a whole collection of volunteers who were out there sewing masks, and then we took them out to all of our churches to get it out to all the people. I mean, being on the street allows you to see and solve the problems as they arise, and that's needed more now than, or it's always been needed, So it's the same, and I think as medicine gets personalized, as AI does wonderful things for medicine, okay, all of these advances, we will be part of helping it share it. We will be part of helping build the bridge between the community and the new world.
Well, that is so important, and you've laid out some of the things like COVID, but there's been, and the diabetes epidemic, so many things over these years that I know you responded to, the opioid crisis, chronic pain, all of these things. But we're getting a lot of questions in the chat, and I'm going to synthesize them a little bit. Some are shout outs to Nancy, who they're very happy to see again presenting. So Nancy, your fan club is represented in the audience. But I think a pervasive question that might be on the minds of many people is, how the heck do you get something like this started? You were able to do it. Are you an N of one? Are there people all over the country who are trying to start projects like this? And I know, Will, when we met a couple of weeks ago, we talked about the kind of national website there is where you can register your mobile health clinic to get support from others. But any of you, what does it take to get something like that started and maintain it?
So I'll start with the get it started.
Okay.
And over time, this has changed great. So in the early days, most mobile clinics were, to be quite honest, individuals like me, churches, some hospitals, some federally qualified health centers, sort of anybody, somebody dreaming up and they'd make it happen. And all of us were just like me. We were, scrapping as hard as we could to keep it funded because imagine you run a clinic and you take care of patients every day, but you're not allowed to charge them. So everybody's out there doing the work and then go home and write the grants so that you're allowed to do the work. So it's not a great business model. Times have changed. People have discovered that mobile clinics actually do great things. We publish work showing that there's actually a return on investment, that prevention actually matters. So HRSA funds federally qualified health centers starting mobile clinics. There are a lot of health systems that have started mobile clinics that actually have fleets of mobile clinics. Mass General Brigham just opened 2 mobile clinics. People have discovered that, I call it the porch to the medical home. It's a way to get people into the healthcare system. And so we're seeing it expand. So now there are lots of ways to start it. There are lots of ways to keep it running. But there's a lot of work because many of us still don't charge for what we do. Prevention, even in the doctor's office, doesn't get paid for enough to keep anything going. So the system needs some rejiggering so that things that actually make people better get paid for. And that's where we are today.
Perfect. And, maybe Will and Tyler, I'm going to ask you to expand a little bit on what Nancy has talked about in terms of the nature of vans and how they've changed over the years, and people are starting them. If anyone hasn't seen a mobile health van lately, they're pretty sophisticated. Nancy, I think you'd agree with me in terms of some of the supplies and equipment they have, but it does come down to this trusting relationship. And, maybe Will and Tyler, talk with us a little bit about your experience. You're the medical students from Harvard, but you've entered into the patient zone, and the community health worker, I think, probably is the captain of the ship on the medical van. Nancy, would that be accurate to say that the community health worker is sort of the captain of the ship? Tell us a little bit about that relationship, what you learned about what a community health worker does, and what you learned about building trusting relationships with patients in that context through that experience.
Yeah, I can get started, and I'll kind of expand on what Nancy was talking about maybe some of the barriers or challenges of starting a van. Of course, I don't have experience myself of pursuing this kind of endeavor, but something that I see, I think it's great that mobile vans are becoming more and more popular, more visible, and a lot of like medical institutions like MGB are kind of, for lack of a better term, like catching on this fad and like trying to like be a part of this movement. I think one thing, in addition to all the issues with like cost and maintaining like the mobile health and being able to pay the people on it, is the idea that it can't just be like a one direction of the hospital is bringing this benefit to the community, like coming to your community and like we're gonna solve whatever crisis is going on in your communities. I think one thing that's people who don't actively work in these communities might not like think about is the fact that a lot of this work has been laid out by members and leaders of the community for many decades. Like they are already putting in this work and effort. They know their community members best. They just don't have necessarily the resources that a big medical institution like right next door would have. And it's really important to actively involve them as equal, if not greater partners in this process of setting up a community-based organization. So like having a community board and community advisors that input on every single step of kind of the initial starting process and the maintenance throughout. I think that is like a really important part that people don't necessarily like think about before they kind of jump into something that they're really excited about. With that, I think I missed a part of your question about. I think it was talking about the importance of like the community health workers and the role they play. And so for me, like personally, they are like integral to like my like supporting me and also like helping us kind of learn about not only the day-to-day of the van, but also like the character of the neighborhoods, the relationships kind of they have with the clients that come to the van. I think without them, like we would be what's the term, like headless chickens, essentially. Like we don't really know what we're getting into. These are community health workers who've been doing this for many years. They come from the communities that they serve. And I feel like they were amazing, like brokers of trust, if in a sense, where like because of the trust they've already established long term over these last years, decades, it was very easy to help transfer that from the clients to us students who are just visitors who are here for like a short term, like month-long rotation, for example. I'd love to pass to Tyler if he has other thoughts about this too.
Great. Well, thank you, Will, and Tyler. Anything you want to add to that?
Yeah, absolutely. I mean, I couldn't agree more with everything Will has already said, and I kind of alluded to this a little bit earlier, but I felt that in working with community health workers who are out in the community every single day, I felt that the focus was so different than when you're in the hospital. Just for as an example, like when you're in the hospital working alongside doctors, like they're giving you feedback on like your clinical skills, maybe how you're doing this part of the physical exam, or like what questions you might be asking to get to a certain diagnosis. But I found that a lot of the feedback I was getting on the family van was more focused around how I was creating space for a patient. I remember one specific time that there was we kind of just like closed a section off of the van when I had a client with me, because they're kind of getting into a little more sensitive information about their own life, just to give them a sense of privacy, and give them that space that is just me and them in that moment, so they might feel a little bit more comfortable than sharing with everybody else. And there was another instance where I like absent-mindedly just kind of sat down close to where I think, Will, you were having a conversation with a client. And I remember kind of after that time, I was not involved in the conversation at all. I was just sitting there. But after that time, one of the community health workers mentioned to me, like, oh, like maybe like make sure like you're stepping out of that space so that you're not kind of like a bystander to that conversation, like a watcher. And that kind of advice is so critical, and it's something that I've almost never been talked to about while I was in hospital training. And I felt that those kinds of skills are so crucial for creating a solid bond and that solid trust, like in addition to just being consistent and constantly in the community and knowledgeable about the community, but just how you go about these interactions. And I really learned from them just how to be a lot more intentional with body language, with how I ask a question, with my tone. And I think that those little things, or not even little things, those things that might seem little in a hospital setting, because they're not in the spotlight, are so critically important to creating bonds, not just between me and the person in front of me, but me and like the community that I'm stepping into. So that's all I'll add to what Will said.
Wonderful. And, maybe I'm going to build on a question from the audience and tie it back to this conversation a little bit. And I was struck by the gentleman in the video that we watched at the beginning. We said, I wouldn't be, I'm going to paraphrase now, I wouldn't be cancer-free 7 years later if it hadn't been for the family van, right? So something went on, may have been education, may have been encouragement to screening. I don't know, may have connected people back to get the appropriate screening test. But it reminds me that part of this trust is to get your partners back in the medical institutions, to be part of this journey and this thread, to build the trust with the patient in the community that they're willing to also access other parts of the system. How, from your perspective, and I'm going to really speak to our medical students and future physicians here, how do you see this building of trust as being foundational to improving health outcomes and addressing health equity issues and health disparities in our communities? Because it's not just about getting trust in you on the van, it's really about getting trust to a whole bigger system. So maybe talk a little bit about that.
Yeah, I'm happy to get started. So I think the way that I kind of saw the family van was as for a lot of folks is that bridge between um, a client in the community and maybe like a nearby clinic or a hospital or something along those lines, depending on what their needs are. And I think that for us on the family van, what I mean like a bridge, like there's a huge gap between somebody feeling comfortable going into stepping into a medical system on their own. But I think with us on the van, we in a lot of ways are just like the family van itself is a trusted piece of that community. And I think it's very different to hear from somebody completely random or from like a doctor who you might not have the best relationship with that you need to receive care. But if somebody like you, again, like your knowledgeable neighbor, like somebody that you already have trust in, even like friends, family, a lot of the times, that is a much easier transition for people. It makes the jump a lot shorter than if they had nobody around them helping to lead them in. And one of the things that I feel is I always put in plugs to my friends about the rotation that I did, the family van rotation that I did, because I feel that even for us as budding physicians, people who are going to be in the field and will be seeing people from all different communities, like I feel it's important for us to have that kind of experience as well, moving forward, because I know that there's so much mistrust in the medical, like in the healthcare system, and rightfully so at this point, at all the history of exploitation, of discrimination, like all of those different pieces added up to a huge mistrust in the medical field as a whole. And so I think that the family van is very helpful in kind of helping to bridge that gap. And I think rotations like the one that me and Will were on are very helpful for growing physicians to step into their field and be ready for that and be ready to engage with the communities that they're going to be working in, because it makes for the entire process be much easier, much less painful overall for a patient to go through. And so that's kind of how I see the role of like the family van, and how I see like for us as medical students who kind of were able to step onto the family van, learn from the community health workers, learn from the community. It's a lot of different steps forward, I think.
Perfect. Thank you so much for those comments. And Will, anything you want to add to that?
Yeah, I feel like when I think about trust and the greater like healthcare system, like we as medical students learn from pretty much day one that the therapeutic relationship is probably one of the most important things to establish in order to be able to provide care for someone. Without it, without your patient trusting you, there's no way that anything you say or recommend could really get to them, right? And then we also learn a little bit about like the historical context for why certain communities are more distrustful of the medical system. And although I will say the medical education doesn't really take ownership of or accountability of that a lot of the times. And I feel like what I see from like the current like academic medical system is that despite all this, they just still exist in their kind of bubble. Like, we're National Brigham, we're here. We provide the best care in the world. You're gonna come to us. You take 2 bus lines. It's gonna be an hour and a half transportation out of your work day. You got kids, and you know what? Like, we can't really help you there. Kind of that kind of stuff. And I feel like the impact that mobile health clinics have is not only like access in terms of like geographical and financial access, providing these services for free and in locations that marginalized communities can actually reach in their own communities, but also in terms of representation. Like that really matters for people to be able to meet community health workers where they're from, to speak their language and know where they're coming from, and also be able to acknowledge and address kind of like the medical trauma and racism and discrimination that has been laid out by the medical system over many centuries and decades, that has led to like this falling out of trust in certain communities. And I feel like mobile health clinics, when they're done well and done right, are that, like Tyler was saying, like that bridge between these communities and like that have traditionally have high levels of distrust for historical reasons, to connect them with the rest of the healthcare system. Because without that kind of bridge, then there's going to be continue to have like a greater and greater divide, and that produces more and more inequities and disparities in the future as well. That's kind of like how I try to think of it in like an overview. Even though like my day-to-day is very much so like tied to like how, when I'm talking to a client from the community, like that's all this is like tied to kind of like the overarching forces and systems that's happening.
Well, we're glad that you're worrying about those things. They're worth worrying about, thinking about, and strategizing how we make sure we protect those trusting relationships. And Nancy, I'm going to let you comment, I think, from your incredible perspective of decades within healthcare, and specifically with this work and the importance of the partnerships, and certainly in sustaining the vans. We're seeing the growth of vans, as we spoke about earlier, different institutions deploying mobile vans perhaps into the communities. What are you seeing, and maybe what are you doing with the institutional partners to make sure they understand this isn't just an outpatient van that is still the outpatient van, but sitting in the community, but is, I think, Will and Tyler spoke so eloquently too, it's a way of seeing into the community, being in community, respecting community. How are you educating people back on the institutional side to make sure that's prioritized?
That's a great question, and maybe not enough. Maybe not doing enough. I've spent years trying to prove the value of vans, and so the first paper is, the knowledgeable neighbor, and that we're doing great work, and we're doing case finding, and we're helping people get better. And then, okay, so we have proved that we make people better, but that certainly didn't change our funding stream. And then, we did a return on investment, trying to prove that there's actually a financial reason, to do this. And, we prevent emergency room visits, and that's great, but that didn't really change the funding stream either. So we keep publishing about the value of the van. We've published its perspective, the patient's perspective, the provider's perspective. And I think that it's sharing that story with the mainstream healthcare, helping them see this whole picture of value. We maybe haven't done it enough. We maybe haven't helped. So mainstream healthcare looks at mobile clinics, and the first thing everyone says is, well, we have neighborhood health centers. What do we need these for? And it's like, well, the neighborhood health centers are our main partners. Because if you work in a neighborhood health center, you actually understand the community, and you understand there are people out there that are not going to come into your neighborhood health center. And so it's really easy for a neighborhood health center to understand the value of a mobile clinic. It's not quite so easy for, a big fancy hospital. I mean, they'll say, well, you can't do surgery on a mobile clinic. And so like, what good is it? You can't follow up. It's like, we're the bridge. We get people in. It's a warm handoff. And so you get to have the glow of the trust we built. And we maybe haven't done enough to help mainstream healthcare understand that value and understand. I mean, if you're a practicing physician and you're, in the middle of the hospital, I mean, I'm so proud that Tyler went and walked around his community. I don't know how many doctors have actually done that. And so you're busy doing your work, and you might have no clue what life is really like for the people who come into your, into your office. And you're going to see, 20, 30 people. Each person is different. How could you ever possibly know the range of things they're coming in with? And so all you have is the sense that these are humans who are living lives that I don't understand. So I have to be open and try to get it. To the extent that we could help the physicians in the hospital see that we can be the warm handoff. We have the time out there to build that trusting relationship. And then if they pick it up with the same non-judgmental, basically love of humanity, then then that bridge will be it'll be unbroken. So yes, I think we need to do more. We need to help mainstream healthcare understand the value in words that make sense, that matter to them, But of course, we're all under the issue of healthcare spending. And so if you're a hospital, you're going to say, why should I spend money on mobile clinic when I can barely keep my clinic in the hospital open? So we do have an issue of where the money comes from and what the money pays for. And that might need to be right-sized. And when we can see the value, that to the whole picture, when we see the value of prevention, it really saves money. If prevention saves money, I mean, that's kind of a no-brainer. But when people believe it, maybe we'll see the finance right-sized.
Well, you've done a lot, and I want to shout out certainly your papers. Also, Will, you had a very good paper with a summary of all the impact on cost and access that have been shown with the mobile van. So very, very important work. None of us ever can do enough, but really appreciate all that's been done so far. I want to make sure we let everybody who is joining the webinar today know that you can put questions in the chat, and those will get delivered up, and I'll try and get them over to Will and Tyler and to Nancy. But maybe we'll take it up a couple of levels for a minute with one question that we have that's not so specifically about the mobile van, but we have two people who are just starting their careers in healthcare, and Nancy, you're speaking with the voice of wisdom and experience in the current environment we're in, the progression of technology, certainly AI, which we're hearing about all the time, and all of the changes in healthcare that are underway, all we've been through with COVID. How do you envision maintaining trust in healthcare and trust in the process of healthcare in these coming years? What are your words of wisdom for everybody?
I think that it is a very good question, and just in terms of AI, it is very hard to keep up with, even like as someone who's been exposed to technology my entire life. I mean, I think that specifically with AI as it fits into like medicine and like how we do this work, I think it is a really useful tool to give you a start, but I think it misses, like, I think that the AI misses out on a lot of, so if you type in like some symptoms that you're having, AI, like ChatGPT and those kinds of things can give you a direction to look, but I think that it being an algorithm of whatever kind it is, I'm not well versed in it, it misses a lot of the nuances of like what people are experiencing and how they want to be treated. So AI can give you a lot of like starting points, but really when you're in conversation with somebody, when somebody comes onto the van and they are able to talk through things that they're experiencing, talk through the kind of context outside of that, like where they live, where they eat, where they do this, that, the other thing, what their life is like outside, that puts into context for us a lot of what's going on in their life, and we get to see how that might play into, oh, why is your blood pressure so high at this point, or why is your blood sugar high at this point? And we learn so much through conversation about about like what people are doing when they're outside of the van that AI I don't think we'll ever have access to, and I think that in itself, like, again, AI being a useful tool creates this massive like separation between in-person conversation and just being able to type something in. As far as it goes in the medicine world, I think it is, again, a useful tool just for like helping kind of guide some diagnoses, but even then, like, you miss out on a lot of that nuance of conversation. And so I think that is, for me, the way I see it, the most major difference between like the work that we do and the work that AI is able to do at this point. And who knows how it would evolve. I can't foresee that or foresee like what the future will look like with that. But I think the bottom line for me is that we will still be needed to keep talking. We would still will be needed to keep listening and understanding. And I think that the clients that come on the van will feel that warmth that comes with that conversation.
Perfect. Thank you so much for that. And I know we are probably coming up on our last 10 minutes, and we have a couple of questions. I still want to I'm going to take one from the audience and then a few more maybe for each of you. But we've focused kind of our efforts, and I think appropriately today, on neighborhoods that may be more prone to health disparities, who may face more structural barriers in getting to healthcare. But do the mobile clinics have a role to play in more affluent neighborhoods and downtowns in the city center? What's your thoughts on that, Nancy or Will? You want to take that on? Should we see you shop wall on Saturday afternoon?
Well, actually, I'm delighted to take that on. The family van was invited to celebrate Larry Bacco's inauguration at Harvard University several years ago. And we were parked right outside the inauguration in front of the Science Center. And we were there for show and tell. And lo and behold, students came by, people came by, and came on the van for services. A few years later, the van was at a health clinic in one of our more affluent neighborhoods, thinking it was just a health fair, thinking it was just going to be, again, show and tell. And people came on for services. So I don't really know the answer to this, say, what, in affluent neighborhoods, but I have a feeling that's an unexplored territory. I know there's a lot of work looking at workforce wellness. And just imagine if the van parked behind your major, organization, so that you didn't have to take the 2 trains to get to the doctor's office. You could go in the parking lot and get your annual visit. So I think there's work to be done there also, that this just might be a flexible, nimble, adaptable part of the healthcare system that serves a different purpose than the fixed clinic. And, it's, build what you need for the purpose that you need.
Perfect. And, the one thing I would say, Nancy, is the COVID pandemic. If you think back to those first couple of months, and Will and Tyler, I don't know if you were in medical school at that point, it was very democratizing around everybody getting in that queue to get the COVID test or to get the COVID vaccine. And I'm sure the mobile vans played a particularly big role in that, whoever was showing up to get care. Let me ask for your advice to those who've joined us on the webinar about the roadblocks. Roadblocks are inevitable. William and Tyler, note to selves. All of your good ideas will probably run up against somebody's roadblock who thinks that this is a good thing to say, wait or hold on or no to. But when we think about the mobile vans, it might take somebody outside of healthcare to really look at the problems and the challenges with the system. How often, the question I think is, how often do you have to resort to begging forgiveness rather than asking permission to just go ahead and do what it is that you think needs to be done? And anybody can take that.
Yeah, I guess I can get started. I think working with the constraints of resources, like bureaucratic policies within the legal system and all of that, like these things take a long time. And my experience with this is mostly me, Tyler, and Nancy are part of another group that established this Office for Community Center Medical Education, which was the culmination of probably years, decades maybe of students and community interest in something like this. And it's just that for one reason or another, I'm sure over the years, HMS just didn't put resources into that. And sometimes these things, I feel like there's very little progress, and then something happens in the world that really pushes this to the top priority. I know at the same time that the COVID pandemic was happening, and we're seeing all these glaring health inequities kind of come up to the surface more. That was the same summer or spring that George Floyd was murdered, and I feel like the country really had a reckoning with racial inequities in all aspects of life, and I feel like that I don't know if directly, but I feel like that kind of movement and like people really mobilizing around this was what pushed a lot of efforts into investigating and addressing these issues. I personally feel like that drive has kind of died down a little over the years, and then with more recent happenings, I feel like it's making a resurgence again. And I guess like for myself, when I think about this, is like really taking these opportunities when these like times happen where there's this window where like things that you've been working on that were stuck, people are actually like looking through now and really interested in like really pushing that through. And sometimes it does take like that really big step, and then you have to like work out the details about how to round it out and figure it out from there, which is a lot of our work with the office that we established too. That's kind of what I guess I can add to this question. Yeah.
Well, congratulations on getting the office established. Big win, big accomplishment. Nancy, I'm going to let you have the last word in this conversation. Any thoughts for the future or takeaway that you would like today's audience to carry with them based on this wonderful conversation?
Well, I guess, I mean, I had thought of, what is the takeaway? And, the title was, this was sort of building trust through community engagement. And I was realizing most doctors who are in the office don't actually have great time to build offices of community engagement. Okay. So what they can do is, we're all taught to be the nicest we can, but it's when you bring to the moment of your interaction with the patient, the knowledge of what the complexity of their life, that makes the patient feel heard, feel trusted and respected. And it's those things. I mean, everybody goes to the doctor because they know something, but people want to feel respected and they want to be trusted. Their knowledge of themselves, they want that trusted. So that to the extent that we as practicing physicians can do that, we will be able to continue the trust that gets built out on the street. But at the same time, there are programs. Many people have asked, what is the barrier to starting mobile clinics? The barrier is all of us don't understand the need for it. All of us in our positions as leaders in our hospitals, leaders in our communities, we all need to step outside of the traditional model and realize that healthcare needs help if it's going to reach every man. And so I think that
I think I have to stop there, but healthcare needs help is a great note to end if we're going to treat every person.